Welcome to another production by the Millennial Mechanical Therapist. Your hosts, Dr. Joseph Gravino and Dr. Clay Case, are two physical therapists trying to treat health issues mechanically. Listen further for patient cases, guest videos, advantages and disadvantages of the way they practice, and much more. Thanks for tuning in today. Check us out on YouTube, Facebook, and at our website. We hope that you learn a lot from watching this video and you come back for more. Hi everyone, I'm the Millennial Mechanical Therapist, and today I want to talk about an interesting case that I had earlier. About 2 weeks ago, I saw a lady who has been having back pain, neck pain, and mid-back pain, so thoracic pain, for about 4 months. And she told me that this pain originally began when she went out on vacation to Florida back in August. Now, I saw her in about December. Mid-December or so. She said out on that trip, her husband convinced her to start body surfing, to try that out. Now, she said she unfortunately had a bit of an accident there. She got caught by a wave that she wasn't really expecting, and what happened was that her head got stuck in kind of like a sandbar there, and she hyperextended over herself. So it actually was a hyperextension moment of pretty much global spine when she went through. She noted immediate kind of cracking, things like that, but she said it sounded more like a cavitation type thing rather than a fracture type. She was able to keep her wits about her. She did not lose consciousness. She experienced immediate pain, but it was all centrally located. So she didn't really think too much of it. She just said, oh, well, I kind of had an accident, and that was it. Now, following that trip for about 4 months, she continued to experience pain in each region of her spine. Specifically in her lumbar spine, she actually had radiculopathy wrapping above the knee to the anterior thigh. Now, it was a little bit groin type position also at the front of the thigh, along with her back pain. Now, that radiculopathy pain was left-sided. Most of her back pain was centrally located, but she did have some difficulty with left-sided neck pain as well that kind of radiated to her upper trap once in a while. However, her chief complaint was her low back pain. Now, she followed up with her primary care physician and was instructed to come to me for PT. During that initial eval, I put her through a full mechanical assessment, and I listened to the things of her history to find a direction of preference, to at least provisionally classify one myself. Now, from her mechanism of injury, it truly indicates an anterior derangement would be very possible. Now, I don't want to count the chickens before they hatch, so we went through more of her history, and she said, you know, I'm a little bit better when I'm walking around in the beginning. I'm worse sitting down for long periods. I'm worse standing for long periods. Bending over is difficult for me, and I feel like I can't bend as far. Standing up straight, really from a seated position, didn't give her too much of a difficulty most of the time, she reported. And she said that lying down tended to increase her symptoms if she did that for a long time as well. Now, two things really popped out to me during that. One was that if you take that whole cluster of findings in general, that really indicates derangement. Typically sounds like a posterior derangement. Now, the one other thing that popped out to me was that she said she had difficulty bending, but then she said, I feel like I don't bend as far. That is very typical of an anterior derangement as well. Oftentimes people will report that they just kind of feel stuck with that, and that was what she was relaying to me. Now, with a posterior derangement, folks tend to have difficulty bending as well, but it's more pain related, whereas in an anterior, it's just kind of like, I can't do it quite as far anymore. And that was what she was trying to tell me. She explained that in her own words for a good 2 minutes. Going through the rest of her history, she did not show any signs of red flags at all. She did have x-rays that demonstrated no fractures, so I proceeded on with the rest of my testing. Her neurological findings were unremarkable with the exception of diminished knee-jerk deep tendon reflexes. Her left DTR for knee-jerk was diminished compared to her right. Both ankles were diminished, but when I see that, I usually chalk it up to the inability of myself to find those sometimes. Even with as much practice as I've had, that's still a pretty difficult reflex to elicit and sometimes going through. Now, as I continue with the assessment, we went to the repeated movements in classic fashion because I was a little bit confused by the history. It indicated potentially, if you just looked at it, maybe a posterior derangement, but I thought there's definitely potential for an anterior derangement to be here. Now going through the repeated movements, I started classically by doing flexion first. And as I had her do flexion, she actually started getting better and better and better. Now the first couple sets, she said she felt better with it, and I go, well, maybe this is just a paradox. Maybe this is just relieving some of the stress on the posterior derangement rather than actually reducing an anterior derangement. So what I had her do was continue, and we actually went up to about 50, 60 reps that day. And she said that her sciatic pain, her radiculopathy, coming to that anterior thigh, that was reducing. So I had her sit for a couple minutes, and she said it was still reduced. So I sent her home with that. Now, in the next episode here, I'm going to talk about what happened following in that follow-up visit. Today's main takeaway, though, is to remember that derangements by nature are variable, and you should never get blindsided and try to categorize everyone into posterior derangement thinking they need extension. Remember, everyone, move early, move often, and move to end range, because that's where the magic happens.